This is Chapter 13. This will cover pediatric procedures as well as working with the geriatric population. We'll start covering the pediatrics first. With our pediatric patients, the things that we have to be mindful of is although the anatomy is exactly identical as shown in this image, it's just smaller. So we're going to use butterfly needles and smaller devices to work with these patients. The other thing too is that a baby's band might be found on their ankle as opposed to their wrist. And we also need to, obviously, when we do our identification, ID with a parent as well, because most kids under a certain age will not know their first, last name, and birthday. And just a reminder of the anatomy. So we have smaller fingers, smaller veins, hence smaller equipment. So we're going to go to preparing the child and the parent. The child's past experience with blood collection is really essential. Place yourself at the child's eye level to explain and demonstrate the procedure. Establish guidelines with the child and parent. Tell the child that the procedure will be painful and encourage parent involvement. You kind of got to gauge that based on the parent. If the parent has a bad experience with getting their blood drawn, it might be suggested that a staff member help. This again is a Cliff Notes version of the larger lecture, but I did pull in the PowerPoint that you can view online here. The other thing to note is here's some pictures. Sometimes we'll demonstrate, so we might show on a doll or on a parent exactly what we're going to do minus having the needles out. And we might have the child demonstrate, so sometimes you can show them, the tourniquet and see how it feels. In this picture here, the child is using the stethoscope to kind of feel for the baby's heart rate, trying to get the child involved. Restraining a child. There's two preferred methods of restraining a child to immobilize the arm. There's the vertical position. Works well for toddlers. Requires child to be held on the parent's lap and they create like a bear hold, and I'll have a video on that later in this presentation. There's the horizontal or supine position. This is older child lies supine, like this image below, and the healthcare worker on one side of the bed, parent on the other. And this way there's distraction, also assistance, and they used a numbing agent here to make the spot numb so the child can't feel the procedure. Okay, there's also the use of ultrasound now. When using ultrasound or infrared light, it's imperative that patient's arm does not move, as a clinician is using direct visualization and cannulation with a needle. A partner is required to secure the arm flat above and below the intended access site for a successful outcome. And it kind of lays out, it's almost like if we think about it like a road map, but it allows us to feel for a child's vein, which sometimes can be difficult because we're trying to determine size, depth, and on a child, especially with a lot of baby fat, it can be hard for us to feel that vein. So we might use ultrasound. How we handle a combative patient. Children may become combative, kicking and thrashing if force is used. If risk of injury to a child or a healthcare worker is high, we discontinue the blood collection attempt and notify the nurse or the physician. We want the child to be as cooperative as possible, and this is really about getting that parent on board and making sure that they understand what we need from them in order to make it a one attempt. That is the other thing we want to take into great consideration when working with children, is that it needs to be a one and done type of procedure, because a child may not allow you to make a second attempt. There's psychological response to needles and pain. The best room location for a painful procedure is a treatment room or away from a child's bed or playroom. Use shorter needles if possible, keeping threatening looking supplies or needles out of sight. They can be underneath a cloth. And place goggles or face shields on after greeting the child. There's also a treatment bed that has a strap, as shown here, that would be really helpful for younger kids so that they just don't roll over. I'll go to decreasing needle stick pain, then we'll go back to the psychological response. Decreasing needle stick pain, we can use a topical antiseptic or spray. It's applied to the skin as a patch or a cream and is then covered with a transparent adhesive dressing. Its optimal anesthesia occurs about 45 to 60 minutes and may last as long as 2 to 3 hours. And we do not use this if the child is allergic. And as shown in the image, it's an ointment that goes on and a patch goes over it. It's really helpful. There's also numbing sprays, but take in mind it does take a little while for it to actually go into effect. So we would have to apply the ointment and then come back later to draw the patient. The psychological response to needles. A 1 to 2 year old give me 1 second. May have extreme reactions to painless procedures, such as taking a temperature. So they're going to be, even taking a temperature here, they might scream. They don't understand what's being done. And here's a brief video that I will show you. This child's a little over 2, and this will display probably the best reaction to a blood draw. These technicians are going to utilize this thing called Quiggles that shakes. It's a distraction technique.
What's Quiggles doing? Shaking. What's he doing? Look at me. Hello. What's Quiggles doing? Brooke, what's your Quiggles?
Okay, so again, kind of a reactionless response, which is not uncommon, but generally kids obviously will say it will hurt. Our 3 to 5 year olds, I'm sorry about that, I'm trying to get on the screen here, perceive pain as punishment for a bad behavior. So a 3-year-old responds well to the distraction technique, blowing bubbles, pinwheels, counting, reading a book, looking at a video. So I'll show you this technician's distraction technique, which was really good. This would be a normal response. This child is 3.
What color are my gloves? What's this color?
Say purple.
Purple. I'm gonna give you 1.
You.
Okay.
This is that vertical positioning, having the parent hold the child across her body and helping assist by holding the arm.
You can hear the squeaking? Look. Do you know that your arm is squeaking? My butterflies say good morning. Can you say good morning? Say good morning, Mia. Yay, the chocolate is coming.
Wow.
Woo-hoo. You want some chocolate? Yay! That's Mia's chocolate. I hurt you? I'm sorry. I was trying to show you the chocolate. You want me to take it out? I'm sorry. I apologize. I did not mean to hurt you. I just wanted to show you the chocolate. Thank you for the chocolate. 1, 2, 3. Thank you for the chocolate.
Okay, so trying to make it as distractful. Obviously the child knows that it's going to be painful. So that's a normal reaction, and hence why it's a one and done. If we had to do this procedure again, it'd be very hard to convince the child to go through that process. Our 6 to 12-year-olds are more likely to relate pain to past experiences, so they'll remember if the blood draw hurt, or they'll remember having to be in the hospital. They start realizing that certain things might be painful, so it's really helpful to just get the parent involved. Our 13 to 17-year-olds are frequently embarrassed. I'm sorry about that. Embarrassed to show fear. I'm going to show you this next video, and it's more so to show you the things we wouldn't do in the circumstance of a patient fainting, but also give you an idea. This patient is about 13 and kind of shows signs already, but there's a lot of things in this procedure that are done incorrectly that I want you guys to notice as well. As you can see, the patient's face is looking kind of more pale, very worried. The technician just told her, please don't pass out. Technician's also not wearing any gloves during this procedure. Patient is also semi-conscious, and they're going to get ready to try to give her water, which is not advisable.
Rachel, water.
Here's the water. Rachel, here's the water.
If she's going to spill it out of her mouth because she's not actually awake.
Rachel, are you?
So the appropriate way we would take care of that is find out if the patient has any history of fainting by asking if they've had their blood drawn before, and if so, how'd it go? And then proceeding from there, we would also then have the patient in a laying down position to avoid kind of that translucent loss of consciousness, and we would wait for the patient to actually wake up before giving them any water. Obviously the tourniquet's face down and no gloves is a serious issue in that video, but just kind of showing you that age group. She seemed fine, didn't really express anything too much. It was kind of very quiet when she should have spoken up more. Newborns, neonates and infants younger than 3 months usually do not require restraint. They can be managed by the healthcare worker alone. So swaddling and leverage is also key. They'll swaddle the baby, and so that keeps them nice and warm. Just like in this case, they have the baby in a comfortable position, giving them a pacifier, and this is collecting of a PKU, which we'll talk about in a little bit. They do use sucrose. It's a 25% solution of sucrose, can be prepared by mixing 4 teaspoons of water with 1 teaspoon of sugar, carefully administered by oral syringe, dropper, nipple, or on a pacifier. The sucrose nipple is given 2 minutes before the heel stick, and it actually creates a numbing effect for the baby, and it lasts about 5 minutes, which is helpful when we're doing any type of procedures for newborns. That concludes Chapter 13, Part 1. Please pick up on Chapter 13, Part 2 to finish this PowerPoint.